Um, Welcome. My name is Dr. Wing Ing, and I'm very honored to be invited to give this talk. With the Brain Injury Association, the idea of successful transition to the community is a very obviously, close to home, close to you guys home, but also close to my heart. The things that I often deal with in the aspect of successful transition to the community is talking about behavioral changes. And so I thought that it would be a good thing for you guys to have my take on it. And from a rehabilitation medicine standpoint, how to handle it, and also the medication management that a professional would use to kind of help the situation. And when I talk about acquired brain injury, that's just kind of a catch-all term for all brain injuries, not just traumatic brain injuries, but also anoxic and other encephalopathy or infection-related changes to the brain. So what I'm going to do is kind of give you kind of an overview and talking about some of the common behavioral changes that may happen as a result of a brain injury, and some of the behavioral and medication managements that we try to use. So what is going on? Do know that you're not alone in all this. Many people, as you know, in this community with this Brain Injury Association, have a good support system already built in, and many people go through the same ordeal. And it's not just a thing that you have to deal with yourself, but also the whole family come together for this. Um, I consider the community as your family also, so it's important to not just feel like, you have to kind of isolate yourself going through this. And the second thing is that, some people think that, oh, I'm going through this and I must be going crazy. No, this is kind of something that's very, very common that I see in this population that I take care of. And so, you guys who are perhaps dealing with some of these things that I will be talking about, do know that, it is something that is physiological and certainly can be managed and dealt with. And things that we often want to encourage people to do is to talk about it. Talk with your family, talk with your friends, talk with your religious community, but also talk with your health professionals, because they may offer things that um, on top of what your community is able to provide in terms of coping mechanisms and just dealing with kind of the support system that's out there. So the things that I kind of look at, you can divide it up into two broad categories of behavioral changes: the ups and the downs. So ups obviously are kind of like things that more excitatory in behavior, and then the downs are more kind of depressive behaviors. So the first in terms of the ups is the agitation. Agitation is something that is defined years ago by Dr. Sandel and associates as an unpleasant state of extreme arousal with increased tension and irritability. And it can come on, suddenly, or it can kind of gradually build up and kind of like a volcano kind of just, explode after it builds up over time. And it can last for a few minutes or a few weeks. And it often occurs during the period of post-traumatic amnesia. That's when it really surfaces. But then it can persist over time as the memory issues improve. Um, there are some association with confusion, hyperactivity, being kind of some hostile activities. there could be some aggressive behaviors, and also with some emotional lability, and we'll talk about that later. And important to know that agitation is kind of distinguished from mood and thought disorders, some more kind of classic psychiatric DSM-5 type of things that the psychiatry would be dealing with. And we often look at agitation as, overall not a bad thing. It's actually a part of that neurologic recovery that we hope to see. And just keep in mind that agitation is a symptom and not a diagnosis. So, usually, it's due to something else, and it's not always possible to identify what that something else is. But please know that you cannot just rest on the fact that somebody is agitated and then that's it. There is something behind it. It can come from internal or external sources, and the people around you when you're in an acute care or the rehab setting, the nursing staff, therapy staff is very helpful in assessing the baseline behaviors as well as an impact of treatments, and even family members, support system, who know that person well can certainly be very vital in helping us to figure out kind of the big picture, because agitation, for me, agitation, when I see a person, I only see the person for a brief moment in time in their life, and so, but the family members are the ones who will see them 24/7 and get a sense of how the pattern is. So there are, internal sources of agitation, things like pain from other injuries, from urinary obstruction, if there's problems with urinating, or having some issues with infection somewhere that's causing pain, or it could be a neurologic issue, like increased intracranial pressure, hydrocephalus, or a mass that's underlying this whole process. And and again, this I'm talking about kind of the overall broad category of acquired brain injury. So with a traumatic brain injury, we're definitely talking more of of other complications that can happen as a result of trauma. So these are things that we kind of want to look at from an internal source. And then external sources of agitation are more obvious. You can see and hear and touch. The things that we don't want to do is to overstimulate a person, and that is a potential source of agitation. Just imagine, if you're in a room by yourself, you can really focus better. But if you're in a room with 10 other people and everybody's talking, the noise in that room can be overwhelming to even a person with no injury. And so for a person who has an injury to the brain, their ability to filter those sensory stimuli is not as good. And so that malfunction causes everything to kind of flood the brain, so to speak. And so you can get agitation as a result of the overstimulation. It can also be from just other things like, in the acute setting, when somebody has a Foley catheter still in, or uncomfortable position, or even restraints. And those are things that can be a source of agitation. Another aspect that we could talk about is mania, in a kind of broad category, bipolar disorder. I put DSM-4, now it's DSM-5. And it's characterized by sustained change in mood and activity. So there's problems with sleep, increased energy, feelings of kind of grandiose delusions or thoughts, meaning like, I can do everything. I'm invincible. And there's, irritability and just kind of flights of ideas where, they talk kind of one thing, going from one topic to another in a rapid succession. And mania can happen with a lesion in the temporal and orbital frontal cortices, kind of where we have the executive control areas of the brain in the frontal lobe. And with TBI is associated with a 5 times increase in risk of developing bipolar disorder based on a study by Van Riekum. And it may also manifest with depressed mood or psychotic symptoms. Obviously bipolar is kind of, you can have one or two of the extremes or cycling between the two. And the extremes is where you can see some of those hallucinations and delusions. Well, in a less obvious kind of thing is just general anxiety, that feeling of fear or nervousness that is kind of out of proportion to the situation. And, people that live with anxiety often live with that, not knowing exactly why they're feeling anxious, that they just feel anxious. And in an more extreme case, it can go into a panic attack that can be kind of debilitating and life-changing. And anxiety can be just kind of a result of situations that may be beyond their control, like noise and crowds, being rushed, or a change in the routine. So, for us, for me even, I mean, I like routine, and for people with brain injuries, having a routine is good. It helps kind of order the day and get a better, a person can get a better handle on coping with the life changes. And so having that loss of a routine or change in the routine can certainly cause some anxiety. And again, TBI is associated with an increased risk of generalized anxiety disorders. So, general strategies that deal with some of these things. I always try to use the non-medication route first. So behavioral management strategies would come first. And if at all possible, you get rid of any kind of unnecessary medications. And if we have to take medication, always consider the lowest effective dose, and then kind of reassess on a regular basis. So behavioral management, things like, if you can identify the one or two things that kind of trigger a person to feel anxious or that kind of agitation, then it may be good to kind of remove yourself or your loved one out of that situation so that it doesn't mount up and become a problem that is more difficult to control. So, again, a person who, a loved one or a healthcare provider who knows that person can help give some insight as to how best to prevent the onset or the intensification of the symptoms. If we have to use medications for these things, for agitation, benzodiazepines are, kind of a thing that I don't like to use unless I really have to. Things like lorazepam or diazepam, because they're kind of sedating and you're really just kind of masking the situation. And there are also some issues with some people having the opposite effect with benzodiazepines. and having even more kind of restlessness or agitation from it. So that is a kind of a medicine that I reserve for select people. Um, and some of the other medicines that I often use are the atypical antipsychotic medications such as quetiapine, risperidone, olanzapine. They're more better tolerated than the older generation things like haloperidol or Haldol, because they have fewer extrapyramidal side effects, EPS, extrapyramidal side effects, and it could be also less sedating. Extrapyramidal side effects are things like people developing Parkinson's symptoms or movement disorders as a result of taking this class of medication. So again, I use it judiciously on patients that have agitation. Um, so things that I can use more often is using for agitation is to use an anti-seizure medication such as valproic acid or carbamazepine. Those two are classic, medications to help control seizures, but they're also useful for treating agitation. And I often use it with that understanding that this class of medication will work over a longer period of time. You have to take it a longer period of time before you actually see the effects. So in some ways, if somebody is dealing with agitation and you have to deal with it right then and there, then I may have to use something like the atypical antipsychotics just to kind of get a handle over things. But then at the same time, use this class of medication like the valproic acid or carbamazepine to get a better handle of things over time, long term. The one thing that we do have to watch out for is its, side effects with everything, obviously, but, with this class of medication, we have to watch how it may affect the liver. So, if somebody's on that medication, I would watch the liver enzymes on a regular basis. So mania, treatment for mania is kind of similar in terms of, it's, in terms of the kind of treating the symptoms, but also looking at the kind of the basis underlying the mania. So if somebody is really having bad manic episode, something to kind of help calm them down, maybe of a good use for that for a short term. I don't advise using this for long term. Better is to look at some other medications for mania or bipolar, such as like a lithium or anticonvulsants. There's also SSRIs or antidepressant class medications that can be helpful for bipolar. Anxiety, again, you kind of look at how to deal with it without medication first. So it may be useful to look at cognitive behavioral therapies first, and that may be able to help that person to better handle the anxiety or kind of figure out internally what ways to deal with it. However, this is not useful for patients that have cognitive impairments of a moderate to severe kind, because obviously the internal reflection is something that may not happen or may not be very well preserved. So it's not something that it can be used generally for everyone, but for somebody up higher level, persons with higher level brain injuries, it could be useful. If we need to, we can use class of antidepressants, the SSRIs or the the SNRIs to help with the anxieties. And again, benzodiazepines are known to be used for anxiety, but it's not recommended as an initial treatment. Again, it's really because of issues of side effects that I want to avoid. And you also do not have to be aware of the kind of the, the possibility of a person being dependent on the benzodiazepines, and that's and then on top of that, if a person's on pain medication for other issues, it's not a good idea to mix the benzodiazepines and the opioid medication class because of its ability to suppress respiratory functions. So going to the opposite extreme now, the kind of more depressed aspects of behavior, the classic depression. These are actually very common symptom after acquired brain injury, that feeling of sadness, worthlessness, change in sleep or appetite, problems with concentrating, withdrawal, the loss of interest, or even thoughts of hurting oneself. And these are kind of symptoms that can happen gradually over a period of increasing awareness. And so in the beginning, a person after a brain injury may be more kind of blunted affect, but not really have that problem of feeling sad. But as the person becomes more aware of their own self and their situation, then that can come on and be a quite significant impact on one's lifestyle and recovery from the brain injury. But also keep in mind that depression can have a physiologic or organic etiology. So people that have hypothyroidism, if it's undiagnosed or untreated or not treated well, can go into a state of depression or appearance of depression. Parkinson's disease, Alzheimer's disease, they can certainly manifest with some aspects of depressed mood. And so, with a brain injury, often you can see some hormonal abnormalities. So when somebody has depression, a healthcare professional would often need to kind of check the hormones, make sure that they're in the normal levels. I always try to explain to people that when they're feeling depressed, that yes, it could be a situation, realization of the problems that they're dealing with, but it also could be a very real physiologic reason for it, a chemical imbalance in the brain that can cause that depressed mood, so that it doesn't they don't feel like they are at fault. So I often explain that to my patients to make sure that they understand that. And so it also kind of helps to explain to patients or the family why I would want to consider using medications to deal with it. And the classes of medication for depression, again, the antidepressants like the selective serotonin reuptake inhibitors, SSRIs, or the other class of serotonin and norepinephrine reuptake inhibitors. Both of these are commonly used for depression. But there are some special considerations of a couple of medications that I use kind of in a way to kind of kill two birds with one stone. The mirtazapine or Remeron is a medication for depression, but it also has a way of helping with sleep or decrease appetite. And so If I'm dealing with somebody that has a insomnia problem, um, getting their days and nights mixed up, then Remeron is something that I may consider. Same thing if there is already a issue with decreased appetite, we may want to use Remeron in the setting of helping with sleep and helping with weight gain. And then the other one is Cymbalta or duloxetine, and it's actually approved by the FDA for diabetic neuropathy and fibromyalgia. So if there is a concomitant pain syndrome that the person's dealing with, then it may be a good idea to use this medication to help kind of take care of multiple fronts. So, it goes back to my belief in, less is more. So the fewer medications, the better, really. So if I can use one medication to address two problems, that is preferred. Now, this is an issue that I see in the arising during time the person's with me in the rehab setting, but they can kind of linger on even after discharge. Problem with decreased initiation. It's difficult to start an action, behavior, or thought. So sometimes you have to kind of remind them to do something. They know how to do it. They just can't get themselves to do it. And uh, the person may not feel depressed, but it's just that idea of, okay, how of getting out of, even just getting out of bed requires a lot of coaxing, and so it's kind of hard to kind of see tease out sometimes, whether a person is depressed or just have a problem with initiation. And it may be useful to have a healthcare professional to kind of guide you guys. Um, uh, the another issue that people deal with is the kind of the decreased verbal output, associated with initiation, and so they can be kind of quiet and only speak when spoken to, and again, that it's it you have to kind of tease it out between if it is actually an initiation problem, or is it more of a problem with uh, depression. And this is a more of a disorder of executive function. Again, this is in the frontal lobe and orbital frontal region that is controlling kind of the the brain's ability to plan an action. So a disturbance in the executive function is something that we see a lot in the brain injury rehab setting. And you can see it pop up more when a person is presented with some novel or complex situation. So the more that the brain has to kind of problem solve, the more obvious it is. Uh, a lot of times, when the person has a brain injury, some of the automatic things come back much quicker, but the things that require more steps, more organization of thoughts, can certainly become more difficult. So this decreased initiation is a manifestation of that. And how do we deal with that? And from a medication standpoint, the classic one is the use of methylphenidate or Ritalin. A study by Dr. White back in 2004 showed that there was statistically significant improvement in the speed of processing, as well as attentiveness during tasks. And you know, I've used it for many, many years with uh, a good success, I think, for uh, many people. I think you know, the thing that holds me back from using it are the side effects. Side effects that I sometimes I even have to stop a medication because of the side effects that come on, like the increased heart rate or higher blood pressure, trouble sleeping, and increased restlessness or agitation. So this medication, you know, you've heard for it being used for people with ADD or ADHD, and it does help with increasing focus. It just has a lot of, you know, things that we have to kind of watch out for. Now, on the other extreme would be an issue with hypersomnolence, where you have severe daytime sleepiness, um, which is present despite normal quality and timing of sleep. So this is when you have just sleepy all the time, and even to the point where you can't get them to do anything. And it's certainly something, you know, that you know, I see impacting a person's participation in rehabilitation. But you know, even at home, it may have a, you know, very real impact on just a person's ability to be part of the family. So certainly, if that arises or is an ongoing problem, we do need to step in and see what we can do to help. Um, and some of the classic medications for hypersomnolence are the modafinil and armodafinil, or the names, brand names are Provigil and Nuvigil. They are approved for things like narcolepsy. Narcolepsy is the one where you kind of, a person just falls asleep all of a sudden and in the middle of doing something, or even just, you know, sitting there or standing there. Obstructive sleep apnea uh, is another approved indication. Um, Shift work sleep disorder, and is also approved for fatigue related to multiple sclerosis. So obviously, none of these are related to traumatic brain injury directly. Um, and so, you know, I use this class of medication in the acute, in the hospital setting. But please know that there's, you know, oftentimes difficult to get outside of the hospital because it is not FDA approved for the population of brain injury. So it's, you know, I can certainly try, but you know, I have not had much good success with getting approval for that. Um, this is a very interesting thing, pseudobulbar affect, or PBA. And you may have seen the commercial. I think it was who was it? That guy that was in Lethal Weapons. um, the actor, you know, he was like the spokesperson for that. But pseudobulbar affect is where you have kind of involuntary and uncontrollable outbursts of apparent emotions like crying or laughing. Um, and what separates this from a real problem of mood is that this is not connected to their emotional state. So they may actually be crying, but they say, I don't feel sad. I'm just crying, or you know, I'm laughing, but I don't know why I'm laughing. And you know, and these things can happen very quickly and then go away very quickly. And then their mood will be completely normal between episodes. Um, and I do see more of a crying than the laughing. And and one of the things that's commonly mentioned is that, you know, they would watch a um, television commercial. Um, well, I used to watch television and watch and see commercials. Now you can kind of like skip those because of streaming. um, but when you watch these commercials and something, like you see a puppy or something, oh, it's so cute, and then a person would cry all of a sudden. That's kind of the classic example of pseudo-bulbar affect. And a lot of times people mistaken it for depression because kind of how severe the apparent manifestation of it is, but when you probe and ask questions, then you realize the person is really not depressed. So keep in mind, not everything is 100%. So there's some people that may have actual underlying depression as well. There is a instrument assessment tool that is made by the manufacturer of the medication that can help providers and even at home family members to kind of rate whether somebody may have a pseudobulbar affect. And this phenomenon is seen in a lot of different kinds of acquired brain injuries. So in addition to traumatic brain injury, you can see it in strokes, brain hemorrhages, multiple sclerosis, Parkinson's disease, ALS. You can see it in people who gradually get demented, and including having Alzheimer's disease. So this is kind of more common than it may appear. The medication that is out for a number of years now for pseudobulbar affect is called Nudexta. And it's actually a combination medication. Funny, I don't know how they actually come up with this combination, but dextromethorphan is in your cough medicines. That's the one of the medications that are in the commonly over-the-counter cough medicines. And it actually helps to stimulate the sigma-1 receptors and inhibit NMDA receptors. So that's what the effects of it is. And then it goes along the combination with quinidine, which is again a classic medication that's used for some other things. This is for like cardiac medication, but the way that it works is that it inhibits the breakdown of dextromethorphan, and therefore it increases its availability in the system, in the bloodstream. And so it actually kind of has a intensifying effect of the dextromethorphan. And so the classic the study that's quoted by the manufacturer is by Pioro as a 12-week clinical trial of using once a day for 7 days, and then every 12 hours of this combination med. And they find that 19% had fewer episodes after 1 week, and 45% had fewer episodes after 12 weeks. And then a third are episode free by the end of that study. So it's quite remarkable. The important thing is to identify and then put a person on this medication if it's truly pseudobulbar affect. So I talk a lot about medications, but really the thing about it is that we need to start with what's available, what you and everybody has access to, which is your brain, your community, your each other, and so your, the medication is really there to help kind of smooth out the rough edges. Um, but the thing is, family involvement or loved ones or community involvement is key to coping with it, and to seek help from a physician if the coping mechanism is not enough. So, and having other people around you, having peer support of people that also are going through the same thing is certainly helpful to better handle what you're going through. So, it's a multi-pronged approach to dealing with these issues. Oh, that's it. All right.
Thank you, Dr. Ng, for that wonderful presentation. I think that is a lot of helpful information from people for people who are transitioning from the hospital to home. That is definitely something that they can refer back to once I upload it to the YouTube, and definitely get that information. If you do you have time for questions? Because there's some people who raised their hands.
Sure.
Um, so if you would like, you guys can put your questions inside the chat, and or I can unmute you when you raise your hand, and you can speak. Whatever works for you guys, you can just put it in the chat. I would like to verbally say it, and then I will do the allow to speak button so that you can speak, or you can just write your questions inside of the Q&A part. I see a hand raised here, so I'm going to go ahead and press allow to speak. Um,
You. Hi, this is Sharon Bannon. Thank you.